I'm Dr. Ryan Prince. I'm a GP at Hampton in Arden Surgery, Solihull, and I've been one of the GP partners here for the last 18 years. Well, a multidisciplinary team is where all stakeholders who can look after a patient come together and discuss the holistic care of a patient. So, for example, in diabetes, that might be myself, the practice nurses, but also we're very fortunate to have pharmacists who specialise in diabetes, a consultant diabetologist, dietitians and diabetes specialist nurses. So the role of the multidisciplinary team really, I think, is to think of all aspects of the patient's care that some parties may or may not have thought about. So where the consultants and the specialist diabetes nurses may think a patient needs very different medication or a different line of treatment, perhaps we at the practice know that a particular patient wouldn't be able to do that from our long knowledge of them, and vice versa. The consultants and the specialist nurses may know far more about the up-to-date treatment of diabetes than we do. So it's a very good way of putting a whole package of care which will actually work well for the patient together. I'd say I'm an average general practitioner with an average working knowledge of the care of diabetic patients. I don't have a special interest or expertise in diabetes, but I feel I'm exactly the sort of general practitioner these things benefit the most. Well, I suppose there's several groups of people that the MDT discussion has benefited. The first group can be the young, poorly controlled diabetics who are having problems getting into the surgery to get the adequate care that they need. And the multidisciplinary team have been very helpful, not only in suggesting what can be done, but actually contacting the patient themselves to give an added layer of invitation to healthcare. And that's been done with both the dietitians, the nurses, the consultant has emailed and contacted patients that we've been having difficulty getting hold of. So they're a very vulnerable group and they access healthcare poorly. So that's one group I think it's been very helpful for. Another group of people perhaps have been the slightly older type 2 diabetics, where we have them on quite a lot of therapy and we're still not getting very good diabetes control, where those people perhaps are not keen to start insulins. And the MDT has been incredibly helpful at enlightening us on the other types of oral and injectable medication that can be used to help them. And with that knowledge that we can go back to the patient with, we can then sometimes persuade them that the alternatives could be worth a try. And we've had some excellent success with some resistant type 2 diabetics whose control has become a lot better after the information we've had from the MDT. So those would really be the two groups of people who've gained the most benefit from the knowledge that the MDT has given us as a practice.
So my name is Hanadi Al-Qadar, I'm a diabetes lead pharmacist. So my role in the MDT as the pharmacist is to do some preparation ahead of the MDT itself. I will prepare some information about the patient, I map them against the NICE diabetes care processes. So we look for any gaps in their diabetes care. I also do a general medication review, so I will look at all the medicines that the patient is taking, the diabetes drugs and the non-diabetes drugs, so that we try to streamline what the patient can take, try and help improve compliance, and if there's anything that needs tweaking to help improve their diabetes control, their blood pressure, their cholesterol, we bring all those recommendations to the MDT, and then we have the conversation with the doctors and the specialist nurses in the MDT to see what plan we want to take forward for the patient.
So I'm Dr. Muhammad Ali Karamat. I'm a consultant physician in diabetes endocrinology. My role in the diabetes MDT is to provide the input in terms of diabetes management, particularly with regards to any advice regarding insulin management or management with any of the other agents that are used to treat diabetes. So we look after the whole spectrum of patient management, including their looks at their diabetes, but we also look at other aspects which are as important as diabetes, for example, their blood pressure management, their management of cholesterol, their lipid levels. And my area really is to actually provide more of the expert input in terms of which diabetes drug, for example, may be suitable for a specific patient, or in some instances, for example, provide more specialty expertise like somebody who may be suitable for more advanced treatments such as insulin pumps and things like that.
So my name is Trishna Patel, I'm one of the diabetes specialist dietitians and I work as part of the community diabetes service.
My name is Ruth Cook and I'm the operational lead and one of the community diabetes specialist nurses. In the MDT, I'm helping to upskill the GP and the practice nurse in diabetes. So it's looking at where there's a gap in their knowledge and supporting them in looking after patients that they might find difficult to manage. It also helps to raise our profile as the community diabetes service, because then they understand what we are offering and when they need to refer. And it helps to also bridge the gap between secondary and primary care.
So my role in the Diabetes MDT is to obviously consider the patient's sort of main features in terms of their diet and their lifestyle, and how, again, through education we can better upskill the practice staff in being able to have those conversations about managing their diet and lifestyle better. We also can raise awareness about our structured education programme. So we currently run the expert course, both the generic and the expert insulin. So it's about being able to tell the practice staff that this is what we offer, this is what it involves, so that they feel better equipped at having that conversation with the patients. We feel from our perspective that the practice nurse is generally a better person to have that conversation with the patient, because they generally have a better rapport with them, they know them better, so usually that conversation happening from them will engage with those patients better.
And because we've worked closely with them, we actually invite them to come into our structured education sessions, so they actually get to see a taster sample. So then when they're talking to patients about it, they're actually telling them from their perspective and their experience.
What makes an MDT valuable is that all professionals there have a shared common goal. We're there for the same purpose, and it is to support those practice staff in delivering better diabetes care for better and improved outcomes. We need to make sure that the patient is at the heart of all of those conversations that we have, and that we don't lose sight of the fact that there is a person behind the conversations that we're having. So I think from the MDT perspective, communication is really key, and I think we all are quite good at delivering that. The fact that we then have conversations outside of the MDT, so we follow things up via email, makes it a much cohesive team that we work with.
It's really helped us to break down any barriers between us and the GP and the practice nurse, because we've got to know each other, and we pass the email addresses, we have telephone conversations. So if we have a referral in and we don't understand, we can just get onto the phone and they actually know who they're speaking to. So it's really improved communication, and also that's reflected in the patient care, because patients see us as one team. So in the past, where it's been confusing for patients because they've had diabetes in the surgery, then they've had it in community, or they might have had it in secondary care, patients are beginning to see that it's actually one team, and hopefully in the future it will seem like a seamless team as well.